Hi, this is Medicine with Faizan, and this lecture is about atrial flutter. Atrial flutter is not as common as some of the other atrial tachyarrhythmias. We have already covered supraventricular tachycardia, or atrial tachycardias. You can see atrial flutter accounts for about 1/4 of the atrial arrhythmias you might see in an emergency room, and it's a very specific kind of arrhythmia that's caused by rapid signals originating in the top chamber. So imagine you've got this electrical signal that's going around in the top chamber. You will say, well, that's a lot like atrial tachycardia. The difference is the rate. In atrial flutter, what you expect to see are rates in the range of 220 to about 350 beats per minute. So if you see heart rates in that range, then you can correctly classify it as atrial flutter. Now there are different kinds of atrial flutter like typical and atypical, and the differences have to do with where this atrial flutter is coming from. If it's coming from the right side of the heart or the left side of the heart, it will give you a different appearance on the electrocardiogram. But for the sake of this basic course, I want you to understand that anytime you see atrial rates in this range, we are talking about atrial flutter. But there's one thing that sets atrial flutter apart from other arrhythmias like atrial fibrillation, and that flutter is an organized arrhythmia. That means that all the beats look the same, but because the atrial signal is consistently going around in a circle, or consistently arising from one spot in the atrium, what you see is characteristically a sawtooth pattern of electrical activity in the atrium during atrial flutter. Now sometimes it's a nice looking classic sawtooth, but sometimes you'll see different kinds of sawtooth patterns. The point is that during atrial flutter, the atrial signals always look the same. On occasion you will see more of a sinusoidal rhythm, and what you are really looking for is a heart rate somewhere in the range of about 225 to 350. So that's how you are going to make the diagnosis of atrial flutter. Of course, you will see QRS complexes in this rhythm every now and then, depending upon how rapidly the AV node is conducting. Well, let's see a couple of examples. This is an example of a rhythm strip in a patient who has atrial flutter. When you look at the farthest in this case, you have irregular QRS complexes, and if you measure the rate is 300, 150, 175, so right about 75 beats per minute, and it's really quite regular. And then when you look for P waves, what you see in between the QRS complexes is this very clear sawtooth pattern. If you ignore the QRS complexes, you will see that that sawtooth pattern marches on through. It's very consistent, and in this case pretty unmistakable. Now following the QRS complex, you see that this downgoing sawtooth wave doesn't go down as far as the rest of it. You see how deep these are, and this is very deep. And then right following the QRS, it's not so deep. Why do you think that is? Well, it's because the QRS has a positive going T wave, and when you get the positive upgoing T wave and the downgoing deep flutter wave, when they mush together, the sum of those two signals is a lot flatter than either one alone, because they're going in opposite directions. So that explains why you see how this T wave is going to depress the depth of the flutter wave, and that explains why you have to be careful because you don't always see the flutter waves as clearly as you do in this strip. In fact, sometimes you have to look for them. Now let's move on to some advanced discussion. Atrial flutter with 2-to-1 conduction. It's a very common arrhythmia that you need to be able to recognize because sometimes it masquerades as other things. We were talking about an electrical signal going around in the atrium, and keep in mind that the AV node ultimately determines the ventricular rate, and it's affected by a number of things including age, the presence of drugs, the autonomic nervous system, which means that if somebody does some exercise and their adrenaline levels go up, the AV node conduction will be enhanced. On the other hand, while they are sleeping, their nervous system is in a relaxed state. The AV node conduction may not be as good. And so the conduction of the atrial flutter, remember in atrial flutter, we're talking about 225 to about 350 beats per minute. The ventricular rate can vary dramatically. Let's take, for example, if you have 300 beats per minute under some circumstances. For example, if the patient walks up a flight of stairs, you can get 2-to-1 conduction, and that gives you a ventricular rate of 150. On the other hand, if they're a little bit more relaxed, you can have 3-to-1 conduction, which gives you a ventricular rate of 100. And if they're sleeping, they may get 4-to-1 conduction, which gives you a ventricular rate of 75. And so heart rates can vary dramatically depending upon the patient's activity, depending upon what drugs they may be taking. In fact, if you come to the emergency room Intravenous medications can be given to block the AV node medications like adenosine or verapamil or diltiazem, and these will have a marked effect on the conduction through the AV node. In fact, we often use these medications as a diagnostic tool in the emergency room. Alright, well let's take a look at this ECG. Here is a patient who comes to the emergency room with palpitations. You can see the QRS complex is very regular throughout, and it's quite fast. Here, if you look at a heavy line, you can see the next QRS complex is just a little bit over 400 milliseconds, and it's marching away from that heavy line as the beats go across. So we're talking about a heart rate of a little less than 150, maybe 148 beats per minute. It's very regular, it's like a clock. Whenever you see heart rates in the range of 150, actually anywhere between 120 and 170, always think of atrial flutter with 2-to-1 conduction, because those rates are consistent with this arrhythmia. Now you look for P waves and you see what looks like a P wave in front of the QRS complex. You say, oh, maybe this is the P wave here because it's very consistent in front of each beat. But again, P waves usually have an isoelectric PR segment in front of them, not always. But this just doesn't look like a regular normal P wave. And what you have to notice is this slanty part of the signal and this rapid upstroke, and see this as, okay, well this may be a flutter wave. And in fact, if I was reading this ECG, I would definitely call this flutter with 2-to-1. But how do you prove it? You kind of have to look at each different lead and you have to get a sense, and whether you can perhaps see that second flutter wave. The problem is that often the second flutter wave is buried in the QRS complex, and it's hard to see. B1 is a great place to look, and you can see these upright signals. If you take your calipers and measure these signals, it's about 400 milliseconds. So look in between and see if you see something that falls right in between. And I think this bump following the QRS complex is indeed the second flutter wave. It's deceptive because it almost looks like it's part of the QRS complex, but it's not. It's actually the flutter wave. Sometimes in the emergency room, you can't really prove it unless you somehow affect AV node conduction externally. Now there are lots of different tricks that you can do. For example, carotid sinus massage can activate a vagal reflex that slows AV node conduction down, but you can certainly do it pharmacologically. 2-to-1 atrial flutter is sometimes difficult, but when you see ventricular rates in this range, have a high index of suspicion and try to prove it one way or the other if you're at the patient's bedside. Do an ECG and do carotid massage if you need to, or give something pharmacologic that will break up the AV node and slow the conduction. Now before finishing up our discussion on atrial flutter, I want to show this example that looks deceptive and makes you think about something else. Here's a 12 lead that I really enjoy showing people. In this 12 lead ECG, if you scan at the farthest, you see that the QRS complexes are irregular. There does not seem to be any specific pattern. Some of these complexes are fairly fast, about 100 beats per minute, and this one's a little bit faster, about 120. Then you have a little break in the action. It slows down briefly and then speeds up. Then it slows down again towards the end. So there's no pattern to it. It seems to be irregularly irregular. That makes you think that there's some kind of atrial fibrillation going on. When you look at the QRS complexes and look for P waves in front of them, there do seem to be discrete P waves in front of some of the QRS complexes, but not everyone. This one does not look like the same P wave. This one looks like sort of in between. And some people would be tempted to start thinking about multifocal atrial tachycardia. You see, this one seems to be upright, and then there's one here that may be inverted. The key here is to look at the long intervals because that's where you will see more atrial activity because there's no QRS complexes to get in the way. And immediately I see that there are 2 bumps in a row. Even if you look at AVR, there are 2 negative bumps. When you look at the rhythm strip and lead 2, you see 2 bumps in a row. That basically establishes the atrial rate. The atrial rate here is about 250 beats per minute. Now, do we have very pretty sawtooth flutter waves? The answer is no. What we have are very short discrete flutter waves with a long isoelectric interval in between them. So it looks more like this. It's flutter nonetheless because the atrial rate is 250 beats per minute. In some areas you have 2-to-1 conduction, but towards the end it looks more like 4 or 5-to-1. But this is a kind of atypical appearance to atrial flutter. In fact, we call this atypical atrial flutter. It's one of the types of flutter that you can recognize on a 12 lead. Maybe we will cover the different types of flutter later, but for now, just be able to recognize that you have an atrial rate of 250. And the fact that it looks like you have P waves in front of some of the beats is just coincidental. It happens when a flutter wave just happens to land in front of a QRS complex and gives the appearance that it's a P wave. But in fact, the atrial rate is much faster because the other flutter waves are buried here on the T wave. This one's buried on the QRS complex, and then you have one. And then it's buried in the ST segment and so on. So it's a sneaky kind of flutter that resembles something else. But you need to be able to recognize that in order to make the right diagnosis. So that's it for today. See you in the next lesson.